We now proceed to this discussion titled Seeing is Believing in Community Health Management. The session chair for this session will be Professor Peter B. Barker and our moderator, Professor Chunyi ZHI. And before we invite them on stage, I'd also like to introduce to you our guests joining them at the roundtable, including Professor Peter JEZZARD, Dr. Stanley K.F. Tam, Professor Guanshu Liu, and Professor Jun Pu. Now, a round of applause, ladies and gentlemen, and welcome our guests on stage for the roundtable discussion. Over to you, Professor Barker and Professor ZHI.
Okay, so I'm honored I'm moderator, right? Okay, so simply we just because we only have 20 minutes, let's just start from Peter. You can initiate this discussion, guys.
Okay, thank you very much. Is the mic on? Yeah. So the topic of discussion is seeing is believing. I was thinking about what does that mean, and I'd actually one aspect of this conference is the idea of screening populations and making some intervention to improve health at the screening phase, and I'm wondering. I'm not sure if this is a targeted question to anybody in particular, but I'm sort of wondering what with imaging we can contribute here to, say, cerebrovascular disease or cardiovascular disease, say with MRI, above the standard screening that's already being done for vascular disease. Would you like to comment?
Thank you. I thought seeing is believing is I initially thought it was a cultural topic, a religious topic. So, sorry, just a joke. I think my belief is that in the current era, people like pictures, video, little red book, and they more visualized pictures or image can definitely help the population health screening. Give them some data or graph or pictures, so they will more believe in what we are good for them, what we want them to do in a healthy lifestyle, in doing a control of the risk factors. So from population health perspective, I think giving more image or data graph would be helpful in delivering the message. In actual practice, cost is an issue. Theoretically, we can screen everyone with different text or image, but the cost is important. For population-based imaging, of course, is not possible. So we have to do it step by step to have some calculators to screen those high risk. Of course, not only rely on calculators. We need the history of the patient, history of the subjects, and the family history, and other factors that to incorporate, and then individualized therapies. And of course, some people may need more imaging modalities to have delineate the risk and then individualized therapies. Thank you.
I mean, I think I would agree that MRI is probably a second line of kind of population screening, that it's too expensive a technology to be a first line of screening, but maybe once you identify sort of high risk individuals, I think clearly it's a very powerful technique. that has a part to play, but probably not as a frontline technique.
My feeling is for for instance, stroke prediction, it's already reasonably good based on a lot of information that's already collected. My feeling is that the cerebro-vascular contribution to dementia, I think, is actually less well understood. All the dementia screening these days, a lot of it's focused on amyloid and tau, Alzheimer's pathology. But I think the cerebrovascular contribution to dementia is underappreciated. I think that's an area where, particularly, I think MRI could make contributions. So, looking, say, at the flow to the brain, how many white matter lesions there are, and things like that, and how much atrophy. And I think that's an area that perhaps this population that would be worth looking at. So how dementia relates to cerebrovascular disease. Guanshu, I've got a question for you. So how are we going to get theranostics and EVs into clinical practice? So everything, you're showing beautiful results in preclinical models. What's the next step to get it into humans?
So my personal opinion is, so we should focus on highly translatable imaging technology, such as what I show you. We use iron oxide nanoparticle, which is also clinical useful. With that, if the treatment enter the clinical trial, imaging can help the successful rate of the clinical trial. And once they enter the clinical practice, we can use the imaging to help the real application in the clinical. So you have to be smart, think about something is really translatable, and also can give you the spatial information, temporal information, the quantitative information. That's very important for predictor or for monitoring the outcome.
So perhaps if I follow up with that. So, I mean, we actually saw nuclear medicine-based theranostics is already in the clinic. And perhaps you could talk a little bit about how MRI-based theranostics or MPI theranostics, how's that going to be better than the sort of traditional nuclear medicine approaches, and what are the advantages of using these different imaging methods?
Peter, this is a really very tough question for me. Yeah. So I think the advantage of PET imaging, nuclear imaging, is they are super sensitive. They need a small amount of imaging probe. They are able to see that. But I think logistically, not every hospital has the PET imager. They typically don't have the cyclotron to generate isotopes. So that being said, MR has the huge advantage because most of the hospital have 1.5 Tesla or 3 Tesla. If we can make our theranostic work as we expected, then all those hospitals can use the MR-based theranostic and not a PET-based theranostic, although I think PET is great. So for MPI, is still in the phase of clinical, they are making the clinical scanner, haven't got FDA approval, haven't got a commercial available clinical MPI scanner. So I think it's not impossible, but still we need time to see whether they can enter the clinical phase eventually.
So, we talked about screening again, and obviously the cost of the screening is a critical issue. And I'm thinking MPI, is it going to be a cheap imaging technique, or is it something that you could use in a large population?
So MPI, I think eventually if we have the MPI clinical scanner available, they will be relatively cheap. So SPO is just air-based air oxide nanoparticles, so it's not very expensive.
Peter JEZZARD, can you talk a little bit about, unfortunately, the last part of your talk, we had trouble seeing your slides, so we don't know if we can believe them or not. But
Happy to show them to anybody else. I'm very annoyed that they didn't show up.
but you're sort of looking at sort of pulsatile flow measurements and so on. Can you sort of comment on potential clinical applications?
Yeah, well, I mean, our hope is that if we can get some accurate, we seem to be getting pretty accurate measurements. We figured out how to get the physiological noise under control, and especially for looking in the neurovascular system under short distances, you need very accurate measurements to be able to pick up accurate time differences. But we think we can do that. So in terms of clinical application, I think that it does have a role to play, or hopefully will have a role to play in characterizing neurovascular health specifically. Coming back to the previous point, probably that's not going to be in a kind of screening environment, but once you've picked up other potential risk factors, I think being able to have that as a measurement will add to the sort of clinical picture of a subject. In terms of trying to translate it ourselves, we're hopeful that we will be able to use. We have a so-called brain health center, which is in the adjacent hospital in Oxford, and we can access that population with this technique. So we're just going to do a little bit more work on it to make it as patient-friendly as possible, and then hopefully we'll be able to demonstrate the clinical picture in the next 1 to 2 years.
Yes, please go ahead.
I noticed, in fact, our guests, some of us is from university, some of us from society, and some of us from hospital. Right? We all use MRI. We all do MRI study, for example. So I want generally, what is, for example, difference in the university, hospital, society to do this kind of study? Yeah, anybody can take this question if you just, yeah, please.
I mean, I guess in terms of the technology, we're generally, probably, sadly, at least 10 to 15 years away from anything arriving in the clinic. Techniques that we've developed have taken many years to find their way onto commercial scanners and find their way into the clinic. But it would be wonderful if we could speed that process up, because there's an army of researchers and very good techniques that it would be great to see them clinically.
Hospital to you or society to you, how would you collaborate, or how would you?
I mean, we tend to do it through the vendors. So we try to get our techniques deployed as beta test sequences through our industry partners. Hopefully they get picked up by clinicians and tested, they get feedback. If that feedback is good, then they can be turned into the clinical product line. But it's at the moment, it's a very long process.
Professor Pu, if in the hospital, for example, how would you collaborate with academia and the society, and how do you do the study of them?
Okay, I would like to share some experience in Shanghai. Shanghai is the oldest city in China. The average age is the oldest. About those population aged 60 and above is about 38%. So even for the community, actually I think maybe MR or the CT is suitable in hospital, but not suitable in community. For community, and it's most important to use echo, for example, for the coronary plaque detection. Moreover, I think the imaging information should combine with other informations, for example, the blood biomarkers. And if we want to improve the outcome, especially the cardiovascular outcome, we should monitor the modality, multimodality parameters, not only the imaging parameters. In our city, for example, in Shanghai, every year we have the free medical checkup for those aged population, for those aged 60 and above, and each year, and we put the imaging data and together with other blood parameter and other parameters, for example, the lifestyle, and we monitor the change of these imaging parameters. So recently, the risk of cardiovascular disease is lower very much after we take these methods. So I think we should focus on those imaging, including MRI or CT or other in hospital, but in community we should focus on other imagings. That's my opinion.
Or Stan, you have any to share about society, how you collaborate with hospital and the academia?
The society didn't do much the research because we have most of our geriatricians working in the hospital authority, but recently we are more aware of the anti-amyloid treatment and the biomarker for Alzheimer's disease. So we have the medication has not yet been included in the hospital authority drug regime. So there are some university, especially the University of Hong Kong, the colleagues, the geriatrician in the University of Hong Kong are doing some study, population, small-scale study on the use of this anti-amyloid treatment for a small group of patients as a study object. The drug was approved that has been used in the United States or Europe, but it was not currently used in the hospital authority. So they do it as a study. They follow the protocol. The client have to do the MRI scan, and also they have to do the MRI in a different schedule. So this is kind of a study that this society has been working with university in doing the research. So to show the how the local population any difference from the data collected from the overseas in terms of the outcome and the side effect of the medication.
So I have last question. In fact, it's quite technical. When I listened to your presentations, in fact, I was thinking that MRI is quite powerful, but it's more like a diagnostic tool, right? I was thinking, is it possible to combine diagnosis with a treatment? Because when you do scanning, that's because I'm not in the field. Just open mind, just think, right? When you do scanning, there you're interacting with this patient, right? Scanning, right? Take some image or you have some interaction. For example, for some mental disease, right? It's not that it could be severe, it could be not severe. I'm not that happy. Right? If you do the scanning once or twice or a few times, you modify something. Just open question. Anybody, if you have any points you want to come up with, please. Yeah.
So I just want to share something I know for SPL or labeled cells. Actually, there are several papers published like 5 years ago. They can use a specific MR sequence to to guide, to change the trajectory of those SPL labeled cells, because there will be a magnetic gradient, and if they create a gradient locally, they see the imaging, then give a specific pulse sequence, then the cell will move around the direction. I think that is one of the examples I know MRI can be used for treatment.
When a patient is an MRI scanner, of course, they're experiencing oscillating magnetic fields, and there actually have been one or two anecdotal reports that people with severe depression actually their symptoms improve post MRI scanning, but it's anecdotal. So I think we're already over our discussion time, so probably now's a good time for a coffee break, and we wrap up the panel discussion.
Thank you. Yeah.
A round of applause to the entire panel, ladies and gentlemen.